Milk and cookies, yes. So I want to thank the organizers for being so accommodating. This is a lecture that fits best, I think, in the context of what you're going to be talking about tomorrow morning, and unfortunately I'll be out of town, but the organizers are kind enough to accommodate that. So just to switch gears a little bit, I'm going to focus actually on future immunotherapies for multiple sclerosis specifically. There are, as you know, thanks to Dr. Bowen's talk, 70-plus agents in clinical trials. So I'm obviously not going to go through all of those, but I am going to go through several of the ones that are kind of up and coming. And then touch on some neuroprotective issues, but I also know that Dr. Kerr is going to give you a talk on neurodegeneration and neuroprotection on Saturday as well. So again, I'm just going to try to get you to dinner here. Maybe we can advance a slide. Thank you. So let's talk about new drugs on the horizon. We'll split them up between monoclonal antibodies, oral agents, touch on some issues about new approaches to treatment, and then spend a little bit of time talking about what in heaven's name neuroprotection is when it comes to diseases like multiple sclerosis. So we currently have 6 disease-modifying therapies that are approved for multiple sclerosis. They all work. They're all actually very effective. And the good news is that, you know, we have been using these drugs now for a really long time. First of these approved in 1993. So we have a really long track record of safety. You're going to be hearing a talk tomorrow about how it is that a new patient with a new diagnosis can navigate this list and figure out what they want to start on. Much of what that discussion between me and my patient might have to do with these types of factors. So we're kind of always balancing the medical considerations. What's your disease burden? How many flares are you having? What kind of a disease course are you expressing with issues pertaining and specific to you? What are your lifestyle concerns? You know, are you a triathlete? Or are you a stay-at-home person? Or are you somebody who travels a lot? You know, these are all the things that we need to think about to find the right balance for you. Well, in the next decade of treatment of MS, this is going to change. Things are going to get a little bit more complicated. Yes, of course, we're still going to be concerned about patient considerations, lifestyle expectations, what are you capable of, et cetera. But really, what we're going to be balancing in the next decade of treatments is going to be safety. Our drugs are potent, they have specific targets, and they come with a certain amount of risk. So we'll be balancing medical considerations primarily with safety. So that's what I'm going to focus on as I introduce these treatments to you. I'm going to do my best to give you a quick idea of what the mechanism of action is for most of these drugs, because I think that's really interesting. And then briefly on the efficacy, because we have more to learn about that, but as much as we know right now about safety. So that'll be how we approach these drugs. Let's start with the monoclonal antibodies. And I am going to review Daclizumab, which is one of the currently FDA-approved therapies, because it's not exactly still, you know, there are quite a few centers that aren't even really using it very much, so it still remains somewhat of a novel agent. And it's the first of the monoclonal antibodies that's been used in MS. So starting first with Daclizumab, this is a humanized monoclonal antibody. So antibodies, as you already heard, are generated by our immune system, right, when we want to detect and attack something. Well, we can engineer antibodies to detect what we want it to detect. So this antibody was engineered in the mouse to detect a specific protein called alpha-4 integrin. And it was humanized so that more of the protein, if it looks too much like mouse, our bodies become distracted and start attacking the drug as opposed to letting the drug do what it's supposed to do. So this is a humanized version of that protein. And the alpha-4 integrin molecule, we've already talked a little bit about today. This is one of those adhesion molecules that's so necessary in allowing that immune cell to attach to the blood vessel wall, and in doing so, escape the bloodstream, violate the blood-brain barrier, and get into the central nervous system. So this interaction between these adhesion molecules is thought to be pivotal in that. So if you direct a monoclonal antibody, which is a clone of that single antibody, against that adhesion molecule, then you lose the capability or reduce the capability of those immune cells to bind. They then are unable to slow down, unable to violate the blood-brain barrier, and they get flushed along and removed. So Tysabri is now approved for multiple sclerosis in 30 countries. It was recently approved for Crohn's disease, so we're going to be seeing a lot more of its use. This was the drug that was taken off of the market because of 3 cases of an infection that's thought to be potentially fatal. This is progressive multifocal leukoencephalopathy. It was reintroduced to the market, but not necessarily reintroduced with a lot of information. So it's not like we gained a lot of information in that year that we were unable to use the drug in terms of how can we recognize PML, how can we reduce the risk, et cetera. But they did put into place a monitoring program specifically to look for issues pertaining to early signs of PML. So this information is current as of about April/early May. They don't have additional updated information yet. Those kind of get done quarterly, so we'll find out more about kind of the summer quarter soon. But at that time, a total of 36,700 patients had been treated. Of those patients, about 10,000 had been treated for at least 12 months, and 3,600 had been treated for over 18 months. And obviously, this number is a little bit bigger now. The numbers currently on treatment in the United States are around 15,000 plus, and of July 08, there have been no new cases of this potentially fatal brain infection, progressive multifocal leukoencephalopathy. So one of the things that, as someone who prescribes Tysabri, one of the things that we certainly want to do is be able to reduce the risk of PML. And we're not exactly sure how to do that. We're not exactly sure how to try to detect this virus. So this is a virus, it's a slow virus that remains dormant in our body. About 90% of us have been exposed to it by the time we're about 10 years old. And it remains dormant and only comes about when it has an opportunity to do so. And that opportunity presents itself when the immune system is compromised, which is the case here with Tysabri. So in the original clinical trials, they actually were able to detect DNA of the virus in the bloodstream of 5 patients who were in these clinical trials, but only 2 of those patients were actually on treatment, which means the viral DNA can be found in people who are not on treatment. So that's a little bit of a problem if you're trying to screen. And then in the follow-up study of patients who were redosed with medications, there were, with Tysabri, there were 6 patients who were positive for the JC virus. And those patients the treatment was essentially stopped. But there haven't really been any helpful recommendations in terms of what to do. There was a group who did spinal taps on their patients every 6 months. And some patients who received Tysabri might be willing to do that, but certainly not all are. And it's hard to know what to make of what these investigators found. They did manage to find evidence of viral DNA in the spinal fluid of one individual and in the bloodstream of another individual. And the medication was stopped in those patients, and when it was stopped, the viral DNA did disappear. But this still remains a little bit of an issue in terms of how we're going to continue to manage this and hopefully reduce the risk. Other types of problems that can occur, or safety problems that can occur with Tysabri, include infections. There have been cases of opportunistic infections, HSV or herpes simplex encephalitis, meningitis, zoster. In the Crohn's population, we saw some opportunistic infections, and there have been some reports of hypersensitivity to the medication. And that's especially so when patients previously were exposed to perhaps 1 or 2 doses who then didn't get dosed for a long time, a year or 2, and then were redosed. So those patients definitely more likely to become hypersensitive to the medication and develop almost like an allergic reaction when they get the medication. So that's another potential thing to think about. Liver dysfunction has been seen, but it has been categorized by the FDA as rare. So rare would be essentially kind of less than 1 in 1,000, but more than 1 in 10,000. So they're talking about probably about 30 cases, something like that. So liver function is checked on a routine basis if you're on this medication. There have been 2 cases of reported melanoma, and it's hard to know if Tysabri did actually contribute to the risk of that. There are ongoing clinical trials of Tysabri. They're looking at actually doing that plasmapheresis, and Dr. Greenberg described that as kind of dialysis of the bloodstream. So if you can remove all the antibodies out of your bloodstream, can't you remove all Tysabri out of your bloodstream if you should need to? So there are studies looking at that. Egress is the ongoing study of patients who are currently on drug. That's a phase 4 study. They're also looking at using Tysabri subcutaneously. So currently that's administered on a monthly basis every 4 weeks by intravenous infusion. Takes an hour to go in, an hour of observation, but now they will be looking at potentially administering it either by an intramuscular shot or a subcutaneous shot. And then they're continuing to look at the way in which Tysabri impacts the immune system. All right, let's move on to the next monoclonal antibody, Rituximab. This is a chimeric murine human monoclonal antibody. So this has a little bit more mouse protein in the antibody than the humanized version does. This is the target of this antibody is the CD20 molecule on B cells. And this is a drug that's indicated for the treatment of lymphoma and rheumatoid arthritis. So when we look at the development of B cells from the stem cell all the way down to the most mature plasma cells that actually create antibodies, we see that CD20 is not expressed every step of the way. It's only kind of expressed in this mid-range from the pre-B cell to the activated B cell. So if you're exposed to Rituxan or Rituximab, it's these cells that are suddenly, very quickly depleted. And they're depleted by a potential number of mechanisms thought to be primarily antibody-mediated, but there may be some programmed cell death that occurs as well. The Rituximab clinical trials showed a lot of promise. 91% reduction in GAD lesions at 24 weeks, reduction of proportion of patients with relapses. Primary progressive MS study failed to meet a primary endpoint, but secondary endpoints may show some promise. There is a question as to whether or not Rituximab is being pursued in phase 3 trials right now, and that's not because it's not a successful drug, but probably because there's a realization here that this is a little bit more mouse than maybe they would like, and a molecule has been developed, Daclizumab, that's more humanized, which is an anti-CD20 monoclonal antibody. So this will likely be something that moves forward. Unfortunately, it means we're a little bit further back in terms of being able to complete a clinical trial that shows efficacy. But this is will be an interesting avenue of research. And as you see, this is an agent that we might use in MS, we might use it in NMO. There might be some other applications here. Safety issues. Lots of patients have been treated with Rituximab, estimated to be at around 30,000. There have been cases of PML, which is that progressive multifocal leukoencephalopathy, in patients who've received Rituxan. About 23 patients who were receiving Rituxan for hematologic malignancies, and 2 deaths in patients who were being treated for lupus with Rituximab. Infusion reactions can occur, although interestingly in the trials for MS, they occurred a little bit more frequently in the placebo recipients after the first infusion. We can see infections, although in general the rates of infections were fairly similar, placebo versus relapsing remitting MS. What we don't understand yet is exactly how many treatments you need to be effective in MS. This IV infusion is given essentially once a year. So you get 1 infusion on day 1, and generally another infusion on day 14. There are some other protocols where you could get it every week for a month, but basically by that first month you're all done. And then you don't get anything for a year. Now, potentially for a year. The studies have looked at it being given every 6 months. But when we look at the B cell populations, it looks like even after a single dose, those B cells have not really returned back to their normal levels, even at a year. So it is possible that that 6-month dosing regimen might be 12 months, it might be 14 months, 15 months. We're not really sure about that yet. Okay, another monoclonal antibody, Daclizumab. This is a humanized monoclonal antibody, and it's against the subunit of the IL-2 receptor. And the IL-2 receptor, the IL-2 is an inflammatory chemical messenger, and when it meets up with its receptor, it helps to propagate and differentiate T cells that we hope will go out and do what they're supposed to do. Go and find a foreign antigen, go and attack it, etc. So if you can interfere with the binding of the IL-2 with the IL-2 receptor, you could potentially impact that whole downstream effector cells, so the cells that are supposed to go out and produce inflammation. It's approved for prophylaxis against renal allograft rejection. And in a phase 2 study of patients with MS, it was administered subcutaneously every 2 weeks, and there was a fairly dramatic reduction in MRI findings, although not as favorable findings when looking at impact on relapse rate, but pretty well tolerated. Some incidents of cutaneous reactions, injection reactions, no opportunistic infections, though. In other studies that were done in patients who had undergone transplantation, there was really no significant increase in abnormalities in the blood work that was routinely collected. Okay, another monoclonal antibody, Alemtuzumab. This is a monoclonal antibody that targets CD52. So again, another marker on an immune cell, and CD52 is present on a number of different immune cells: B cells, T cells, natural killer cells, monocytes, macrophages, and presumably when Alemtuzumab attaches onto CD52 through an antibody-dependent cell lysis phenomena, those cell populations die. There has been a phase 2 study done of Alemtuzumab that's given once annually. So once annually, against Rebif. And in that study, relapse reduction when compared to active drug, not placebo, when actually compared to active drug Rebif, there was a 74% reduction in relapses and a reduction in sustained accumulation of disability. But there have been some safety issues, and the safety issues that have cropped up as a result of this tend to involve actually the uncovering of some autoimmune diseases. So there have been a few cases of idiopathic thrombocytopenic purpura where essentially the platelets, which help to clot blood, that those are essentially attacked by your immune system, and the numbers of platelets drops in the body. And then there's Graves' disease, which is an acute thyroiditis, so where antibodies can develop to the thyroid. So these things are certainly, it's going to be interesting to see as we follow agents like Alemtuzumab, whether we'll continue to see these types of entities. Infusion reactions can occur, generally mild to moderate. Opportunistic infections have been seen in cancer population. 2 ongoing studies of Alemtuzumab. There's a comparison of Alemtuzumab in patients who've never been on drug compared to interferon beta 1a, and then there are patients who have already been on interferon beta 1a but have already had a relapse while on it. So those are the 2 studies of Alemtuzumab. Am I going too fast? Are you guys doing okay? All right. So let's move on to the oral agents. This is FTY-720. This is a novel orally active synthetic molecule. It resembles, when phosphorylated, it resembles sphingosine 1-phosphate, which is a lipid component of cell membranes. There are 5 receptors for sphingosine 1-phosphate. So there's S1P1, S1P2, S1P3, and 4, and 5. When FTY-720 phosphorylated binds to S1P1 receptors, it induces this internalization, actually, of the S1P1 receptor. And when it does that, it prevents immune cells from exiting the lymph nodes. So I'll show you a picture of that in a minute. It only affects lymphocytes, not monocytes, and these other branches of the immune system. So here we are inside the lymph node. We have a T cell that's going into the lymph node. It's expressing the S1P1 receptor there. And when it is activated to multiply, for a little bit, that S1P1 receptor internalizes itself so that it can divide and multiply and multiply and multiply. We get more and more activated T cells, and once there are enough of them, then they re-express that receptor that's necessary to help them bind to that immune inside of that lymph node, essentially, and get out. Well, when you give enough of something, when you stimulate a receptor enough, that receptor will say, all right, well, there must be enough of this stuff around. I clearly am not necessary. And it downregulates itself. So then the receptor will internalize itself. So by stimulating it and stimulating it, you can actually overstimulate it to the point that you actually block it, because then it feels like it no longer needs to be present, which is what happens here. So by overstimulating it, we actually we downregulate the expression of that receptor, and then these T cells accumulate within the lymph node, and then they essentially never get out. So they can't get out in armies enough to produce MS attacks, right? They can't get out in armies enough to produce lesions. So I did mention that there are 5 of these receptors. There's S1P1, 2, 3, 4, and 5. And FTY720 phosphate is able to bind to 4 out of the 5. It binds to the one on lymphocytes, which we just heard about, but it also binds to ones on heart muscle cells, on the muscle cells within the bronchioles in the lung, and also within the brain. And FTY720 is actually capable of getting into the brain and potentially binding to S1P5, although we don't really know what the ramifications of that binding are. Because FTY720 can bind to all these places, there are potential downstream consequences of each of these things, which have to do with some of the precautions that we need to take in using this and the potential side effects and risks. Originally, FTY720 was studied in patients who were undergoing transplant, and so it was studied in a different population of patients in combination with different drugs. So in diabetics, they were finding in these transplant patients that there was a much higher risk of developing macular edema if you were taking FTY720. So one of the things that is being done in the clinical trials of multiple sclerosis is, number one, they're not letting diabetics in the study. And number two, all the patients in the study are having to have routine eye exams performed. The efficacy early on has been pretty favorable. So early studies have shown a reduction in the GAD lesions and the T2 lesions, as well as a favorable effect on the annualized relapse rate. Most of the AEs were fairly mild: nasopharyngitis, headache, influenza. Not a lot of report of AEs, actually, in terms of side effects. There has been in previous studies a case of a patient who developed an encephalopathy, a leukoencephalopathy of the posterior part of their brain, which may have to do with blood flow, may have to do with the presence of S1P receptors along the blood vessel wall. We have yet to see and to understand that. Some predictable issues include a transient drop in blood pressure that definitely occurs within 6 hours of the initial dose. So all the patients who are in the study are monitored because we know that the blood, the heart rate, can drop. Although for the most part, this has not been a sustained problem. So there haven't been people who have had ongoing issues. It's basically a problem of when you first start taking the medication. People with asthma are not being allowed into the study either because of the presence of the S1P receptors on the bronchial muscles. So this is a little bit complicated because once we get, if this drug should ever be used, we're going to have to say, well, gee, you have diabetes, or gee, you have asthma. Can we use it in you? We won't know based on the data from the clinical trials, but I think there's good reason to be excluding these patients in the studies. Ophthalmic issues, obviously, I said that those patients are being monitored. Liver function tests also being monitored. And routine skin evaluations are also occurring as well. So the ongoing phase 3 studies include a study of 2 different doses of oral FTY720 versus placebo. And then in the other study, there is an active arm where it's also being compared against Avonex. In these phase 3 studies, there have been 2 recent infections that have been quite complicated. One of them was a case of disseminated chickenpox. So someone who developed chickenpox throughout all of their body, and that person unfortunately died. And then a second individual who had herpes encephalitis, and there may have been some issues with regard to delay in treatment for that person, and that individual is still comatose. So some issues potentially with this medication. Again, balancing efficacy and safety. BG12, another oral agent. This is an oral formulation of a fumaric acid ester. The proposed mechanisms are immunomodulatory and neuroprotective. So the idea is it's possible it might activate this pathway that will help in relieving oxidative stress to neurons, possibly. And immunomodulatory-wise, it's been shown to inhibit the expression of pro-inflammatory cytokines. It has really been used for quite a long time as a topical and oral treatment for psoriasis. It has been approved in Germany since 1994. Early studies in relapsing remitting MS suggested there was an impact on the MRI scan in terms of GAD lesions and T2 lesions, but not as robust an effect on relapse rate. Generally safe and well tolerated. It's oral. It needs to be administered 2 or 3 times a day. Flushing and GI events tend to be kind of the biggest side effects that are problematic. But in terms of major safety issues, there haven't been a whole lot of them. There has been incidence of some elevation in liver enzymes, which is reversible. And there are ongoing studies right now looking at BG12. So there's a study looking at oral versus placebo, and then there's a study looking at oral versus an active comparator, so using Copaxone versus placebo. Cladribine. Cladribine is a purine nucleoside analog. It disrupts proliferating monocytes and lymphocytes. It's used in the treatment of hematologic malignancies. In MS, it's previously been studied by either subcutaneous or IV administration. And in those earlier studies, they've basically shown a pretty consistent effect on MRI scans and also somewhat of an effect on disability and relapse rates. Issues with the administration of Cladribine IV or sub-Q have had to do primarily with immunosuppression. This is an immunosuppressant. And some of the cases of immunosuppression have been sustained for a long time. But what they're looking at now is completely switching gears, realizing that, wow, there is oral bioavailability of this agent, switching gears to an oral formulation. So dosing it essentially annually. There's a low-dose group where you get 5 days on week 1, 5 days on week 2, same thing at year 2, and then a higher dose where you're getting 5 days a week for 4 weeks in a row, and then again redosing at year 2. And results still are pending here with these ongoing clinical trials. There's a high dose versus the low dose versus placebo, and then there's the high dose, low dose versus placebo, but in addition to Rebev. We don't really have accessible information about the oral formulations, except for those people who are involved in the clinical trials, and there has been some suggestion of sustained immunosuppression in patients in these studies. Lymphocyte. This is a novel oral synthetic compound. It's structurally related to linamide, which is quinolone 3-carboxamide. And the reason why that's important is that there were some clinical trials done of linamide in the 90s, and it was shown to be pretty darn effective in treating MS and reducing the expression of the disease, but unfortunately it resulted in too much cardiotoxicity. So there are patients who were sustaining too many heart attacks, and they had to stop investigating it. But they managed to find a structurally similar compound, and Lymphocyte is that compound. It's an immunomodulator promoting a Th2 bias, so it downregulates these pro-inflammatory cytokines. It has been studied in early phase 2 studies, essentially showing a reduction in lesions on the brain scan. Higher dose has been a little bit more effective, and the main issue that they've seen is this liver function abnormality, which ends up being reversible even while you're on the treatment. No opportunistic or life-threatening infections, and there are 2 ongoing studies here in patients with relapsing remitting MS, one looking at oral 0.6 milligram dose versus placebo, and the other one looking at that same oral higher dose versus placebo and the active comparator with Avonex. All right, teriflunomide, this will be the last of the orals that we talk about. This is dihydroorotate dehydrogenase inhibitor. This is a metabolite of leflunomide, which is an immunosuppressant used for the treatment of rheumatic diseases, including rheumatoid arthritis. It does primarily act as an immunosuppressant. In a phase 2 double-blind study, when looking at 2 different doses, it did show an effect in reducing gadolinium-enhancing lesions, and fewer patients were shown to experience disease progression, and it's currently in phase 3 development. Safety issues, really, there appear to be very few safety issues with this drug, actually. Most of the safety issues that are of concern come from its parent compound, which was the leflunomide. And the leflunomide does result in some liver enzyme problems, immunosuppression, and is actually a pregnancy category X, so is known to produce problems with fetuses. So that would be potential issue. But again, this is not with teriflunomide. We still have yet to kind of collect more information about that. All right, so let's switch gears a little bit and talk just kind of theoretically about the future of MS therapies. Those are some concrete things that are happening. But is it possible, and a gentleman asked me this at the break actually, is it possible that we'll be able to tailor drugs to match a patient's disease type? Not just relapsing remitting or secondary progressive or primary progressive, but maybe, you know, dealing with some of the more intricate categorizations of patients. So it does turn out that partly by chance, there were patients who at Mayo had a very, very poor response to treatment, poor response to steroids, needed to go on to have plasmapheresis, and some of those patients, for whatever reason, at some point had gotten some biopsies, and so lesions were classified. And in this group of patients who were not very responsive to steroids, who ended up getting plasmapheresis, the patients who did best on plasmapheresis, who showed a very positive response to that, ended up having lesion type 2. Now, it's not an everyday phenomena that you're going to be able to go in and say, take a little piece and tell me what, you know, what lesion type I have. It's complicated because you're not going to want to get biopsies, right, to show what type of lesion type you have. But it is interesting to think that if we could find markers for those disease types or markers for other things, that maybe we would be able to direct our treatment in a way that makes a little bit more sense for that particular individual. We know that certain patterns on MRI scans can be seen that also might help to drive treatment. We know that ring-enhancing lesions are representative of those kind of sharp demarcated borders that we see in type 1 and 2 lesions. That ring-enhancing lesions have not really been described in the type 3 lesions that have more ill-defined borders. So that may help, again, drive treatment. And then there's an idea of genetic testing. I know Dr. Barnes was talking a little bit about genetic testing. You know, in clinical practice, we see patients who are treated with one form of disease-modifying therapy, like, let's say, an interferon, and they seem to just, they just are burning right through it, having lesion after lesion, enhancing lesions, attacks. You switch them to a different class, like, let's say, Copaxone, glatiramer acetate, and wow, suddenly their disease quiet as can be. And we've seen the other, where we have them on Copaxone, they're just burning through Copaxone, having horrible disease, you put them on an interferon, and wow, they get this tremendously positive response. Those are very different immunomodulators, which you'll hear more about tomorrow, but they're different. They act differently. And in acting differently, is it possible that there are certain people who have a type of disease, a type of immunological subtype, a type of genetic profile that might be more responsive to one type of treatment as opposed to another? Well, we're collecting information about one's genetics. So in a combination trial ongoing, looking at the combination of Avonex plus Copaxone versus Avonex alone or Copaxone alone, genetic information is being collected so that hopefully at the end of that study, we'll be able to see, wow, were there people who did exceptionally well on one drug, or were there people who did exceptionally well on another? And is there something that we can learn about their genetic profile? So I don't think that this is necessarily unattainable. Will there be something that we can grasp at or test that will help guide us in terms of which treatment will be most effective for you? What about gray matter lesions? How are we going to treat those? How are we going to measure those? How are we going to see those? So I think this is going to be very interesting in terms of the future of MS therapies. We have no idea how the current disease-modifying therapies affect those gray matter lesions actually. All right, moving on to neuroprotection in MS. Well, this will be quick here. What is neuroprotection in MS? Is it simply the dampening of the immune process as we understand it? Is it enough to just kind of reduce attacks, reduce lesions? Is that what we're going for? So by virtue of being on a disease-modifying therapy, are you already neuroprotecting? Is that what we mean? Is it enough to just impact that T-cell mediated inflammatory process? Maybe, you know, to the extent that we can reduce axonal transection, et cetera, maybe we are. But I think we're talking probably more differently. So is it in reducing axonal damage? Well, axons are vulnerable to attack by a variety of insults. They can come under attack because of inflammation, excitotoxicity, lack of trophic support, apoptosis, Wallerian degeneration. And in MS, it's certainly likely that all of these things contribute to axon loss. So sure, if you can interfere with some of the inflammation, maybe you can protect the axons. But there are also some other direct toxic types of effects on axons that are inflammatory that maybe we could try to impact. So go after the expression of nitric oxide or complement, glutamate excitotoxicity. So this is certainly something that we've looked at in other types of neurodegenerative processes and even stroke. Another thought about how it is that axons essentially disintegrate is this idea of this permeability change. So as the axon membrane becomes more and more permeable, it leads to this uncontrolled influx of sodium. And when you get this sodium influx, the sodium-calcium exchanger, which is trying to, I mean, imagine there's like a little sodium exchanger and a calcium exchanger literally like trying to dump a sodium and calcium out of the axon to correct that balance. So when it's doing that, you get an excess of this intraaxonal calcium because for every sodium you're trying to shut out, you're having to kind of exchange it with taking in calcium. So when you take in calcium, these calcium-dependent proteases degrade the cytoskeletal proteins. They impair axonal transport. These voltage-gated calcium channels then accumulate at these sites of disturbed transport, and we get even more calcium influx, which then results in this disintegration. So if that's what happens with axonal degeneration, then might we look at sodium channel blockers or inhibiting this exchanger or blocking these voltage-gated calcium channels or inhibiting some of these proteases. So these are some potential directed areas at reducing axonal destruction and affording some neuroprotection. Then there's a lot of talk of these various nerve growth factors. Is that what we mean by neuroprotection? Do we want to increase the amount of neurotrophins, nerve growth factors in the bloodstream? Do neurotrophins even help? So there are data to suggest that neurotrophins can provide trophic support to injured neurons and axons, that they can affect remyelination, that they can have immunoregulatory effects and downregulate the expression of inflammatory cascades. So it turns out that the current disease-modifying therapies have, in small studies, shown an ability to enhance the amount of brain-derived nerve growth factor produced by cells. So, you know, I think this is potentially interesting. And whether or not we'll ever be able to just use BDNF or use these other types of growth factors as have been tested in other degenerative diseases like ALS, you know, remains to be seen. And then finally, is neuroprotection in MS, are we talking about promoting remyelination? Is that what we mean by neuroprotection? So a consistent feature in MS lesions is this remyelination. So lesions do remyelinate, especially early lesions, right? We see them in early lesions, we see them along the edge of large lesions, but we don't see it very much in older lesions. We remyelinate by recruiting oligodendrocyte precursor cells. So chemical messengers are sent out to try to bring these oligodendrocyte precursor cells to these sites of active demyelination. And then the oligodendrocyte precursor cells are then thought to kind of re-express or reactivate genes that are necessary to help them to potentially produce new myelin. Well, so you can lead a horse to water, right? You can bring the oligodendrocyte precursor cell to the lesion, but then you have to help that oligodendrocyte precursor cell to mature. And unfortunately, there are inhibitors of that growth and development, and we're just learning more about these inhibitors. If we don't learn about these inhibitors, then there's no way we're going to understand how we can better remyelinate. So some of these inhibitors are neurite outgrowth inhibitor or no-go, jagged notch. So these are all probably important pathways because we don't want nerves to grow on end, right? But at the same time, we need to understand our milieu so that these oligodendrocyte precursor cells can actually do what they need to do or what we want them to do. So in conclusion, I think the future of MS therapies is extremely exciting, extremely promising. Pardon me. And I think there's also going to be a shift in the way that those of us who care for a lot of MS patients think. We need to balance safety with efficacy. And I think that neuroprotection is going to involve several targets. And I think ultimately understanding the repair mechanisms of MS is really going to be what helps to lead to, remyelinating efforts. Thank you. Sorry. Those that are in development, what they most have in common is the ability to interfere with the inflammatory cascade. So to the extent that inflammation is contributing, but they aren't so much helping with, at least as far as we know yet, we don't know the impact on nerve growth factors, we don't know the impact on remyelinating capacity, certainly because we're really just starting to learn about that. BG12 is one of the agents thought to potentially activate through that pathway that reduces oxidative stress on neurons, so that might have some neuroprotective effect, but it's pretty theoretical. So the question was, is the only therapy available now Tysabri? So of the ones that I listed, the only FDA-approved therapy that I reviewed was Tysabri. There are 5 other FDA-approved treatments for, yes, and the rest of those are currently in clinical trial development. Now, Rituximab is prescribable. One can prescribe Rituximab, but getting that drug covered by your insurances can be challenging. So the question is, how can you track the progress of these clinical trials? So there are a couple of places where you can do that. There is a site on the NIH website that does review all the clinical trials that are going on, and then the National Multiple Sclerosis Society keeps a very active list of them. And you can also kind of get on a mailing list, so to speak, an email mailing list through the National Multiple Sclerosis Society, and get updates basically weekly on anything new that came out, on anything that, that in terms of multiple sclerosis. So those are some really great updates you can get very, very frequently.